All right. Good morning for our to all our fellows joining in from the East Coast, West Coast, and internationally. We are here for our October Fellow Project, and we're very excited to have two fantastic speakers and an extra special guest joining Dr. Wilson and myself this morning. Um, First, let me give Dr. Wilson an opportunity to go through some updates and reminders for the month, and then we'll introduce our speakers. Dr. Wilson, take it away.
All right, thank you, Dr. Eckhouse. So welcome everybody. Just some quick announcements and things to be mindful of. First off, for the fellows, just a reminder to keep track as you go throughout the year of your ASMBS certificate requirements, so that you can have your paperwork and things ready at the end of your fellowship. So not only keep up with your operative logs and cases, but also with your outpatient and inpatient encounters, because you have to have a certain number of those, and you will need to keep up with those types of encounters too. So just a reminder for that. ASMBS weekend is coming up. Hopefully you've gotten a chance to register if you're able. The ASMBS weekend is in Atlanta, November 7th through the 9th, but there is a fellows focused course, the Leadership Academy, the 6th to the 7th. And I believe registration may have closed already or soon, but if you're looking forward to that, that's a great opportunity to network and learn and think about the next steps during and after your fellowship. Also, just a reminder, the fellowship project, of course, is the first Friday of the month, and there's a morning and afternoon session. And then our bariatric happy hour put on by the ASMBS Bariatric Surgery Training Committee is on the fourth Thursday of each month. So great opportunity to go through landmark papers and learn from other experts in the field and go through technical aspects through video review as well. Otherwise, a reminder, and for those of you who may be in the ASMBS membership and get those emails, the Trail Foundation is leading a relief fund for victims and those affected by Hurricane Helene. So look out for an opportunity to give if you're so inclined. And otherwise, continue to refer to the ASMBS website for more opportunities, not only to get involved, but for professional development. And let me know if I missed anything.
Nope, I think it was great. Thank you so much. So today our first speaker is Dr. Saniea Majid. She is the current TRIO, which TRIO stands for Treatment, Research, and Education to End Obesity Foundation. It is the foundation associated with ASMBS. She's our current president, and she is an owner of her practice and the director of her practice in New Jersey. She also happens to be a past president of New Jersey ASMBS. And so what better than talking to somebody who's built it than Dr. Majid to talk to us about how to build a bariatric surgery program. Our second speaker will be Dr. Stacy Brethauer, who is the current Chief Quality Officer and full professor of surgery at The Ohio State Wexner Medical Center. Got that right. I added the "the." And he is a past president of ASMBS from 2016, 2017. So we have some powerhouse speakers today that I'm excited to have talk to you. Dr. Brethauer will be speaking on how to become an MBS equipped center of excellence based on his years of experience, not only leading multi-institutional trials through MBS equip, but also helping run the MBS equip through ASMBS and ACS. And then we also have a guest speaker today. Dr. Linden Karras will be helping during our question and answer session, introducing a toolkit that's being put together by the Rural Committee, as she's the co-chair of the Rural Committee. So action-packed today. As questions come up, don't hesitate to put them in the Q&A and in the chat. And Dr. Wilson and Dr. Karras at the end will help, and we will all give you our answers. Dr. Majid, let's take it away.
Great, thank you. Good morning, everyone. Really excited about having an opportunity to participate here. I wish we had this when I was a fellow. This is really great. I have no financial disclosure. I have had the opportunity to successfully build 3 bariatric programs. The first one was for nonprofit hospital in inner city Newark, New Jersey. The second one was for a for-profit funded by private equity. And then the third one is my own practice. So quite a lot of experience. Didn't plan it that way when I was a fellow, but that's how it happened. But tremendous opportunity to learn, and I'm happy to share with all of you. The roadmap of my talk would be building a bariatric program, whether it is for yourself or somebody else, is a strategic and impactful decision. So you really have to think through this. Look at the demand for bariatric services. A good question that I think should be addressed by all of us is why build a program in 2025? How to ride the GLP-1 wave? What not to do. So avoid the mistakes that your attending physicians made, and basically, in full disclosure, the mistakes that I made. Key to a successful program, and then we'll end with a summary. So demand for bariatric and metabolic services. The supply-demand aspect is very important to address when you want to embark on anything like this. So we are all aware of the rising obesity rates. There's clearly an unmet need. There is a need for surgical and non-surgical intervention, so keep that in mind. It's going to be the bariatric program of today has to be different than the ones of 10 years ago, at least when I was in training. It was purely surgical, and we'll talk a little bit more about that. The chronic health conditions are just going up, and they are very much associated with obesity. We all know that. Childhood and adolescent obesity is on the rise. So there is clearly a demand for bariatric and metabolic services today. However, survey your individual market or area to determine the unmet need. So don't just take the national statistics and say that it should work wherever I'm at. So make the effort to understand your market and your area. I pulled this map, as you guys probably have all seen this from the CDC. So this is adult obesity prevalence 2023, does not address childhood obesity, which is on the rise. Do not open a bariatric program in Colorado based on this map. But the point I'm trying to make is that do your local investigation for the need. So market analysis. So market analysis is beyond just the need for the patients. It's the local competition, right? So how many programs already exist there? What is your place going to be? And access and convenience. How far are patients traveling to get care? Because if they are traveling quite a distance and there are some great programs, there would be an opportunity to build a program closer to where you think most of the patients are coming from. Resources and infrastructure. So I'm sure that the toolkit would also outline this. I haven't seen the toolkit myself, but I do want to take a moment to highlight the amount of people behind a successful bariatric program. When I was a fellow, quite honestly, I didn't appreciate everybody's role and significance. So I want to take a moment and outline that every member of your team matters, whether it's the front desk, the office staff, whether they're clinical, non-clinical, your OR team, the quality of care being provided by the floor nurses, the specialists you'll be working with, right? So whether they're pulmonologists, whether they're IR, whoever you're going to be dealing with in terms of care for your bariatric surgery patient, don't think about the same day discharge patients. Think about the ones that actually need ICU care. Are you ready to be able to provide that degree of care? So make sure you think about what your resources are and who your team would be. Behavioral health, registered dietitian, support groups, and then think about call coverage. Very important and appropriate call coverage to be able to take care of bariatric patients that land up in the ER, whether they are yours or somebody else's. Facilities, so specialized equipment is needed, as you guys probably all know, and this is great that this talk is paired with MBS AQIP, because I've always used the MBS AQIP guidelines to help me understand what are the needs that the program has to meet. ICU, IR, GI, weight of the CT scanner, the fluoroscopy machine limitation. These are all things you want to think about. Then let's switch to insurance and reimbursement. Extremely important. You could have a great facility, you could have all the pieces in place, but if you do not have coverage for bariatric surgery, it'll be a game changer. So know your local coverage. The CPT codes, if you guys need that, feel free to message me, email me. I'm happy to share the codes that you would need to check that your area that you're going to be starting your practice in does have coverage for bariatric surgery and the diagnosis of obesity. Know your local payer mix. What's the most common insurance carrier and what is their requirement? And their requirement for bariatric surgery is actually, you should just go online and look up, let's say if it's Blue Cross Blue Shield, you can just look up very quickly what the bariatric surgery policy is. And usually these insurance companies update it twice a year, but definitely once a year. Know your contracts. So these are not your job contract, but the insurance contracts. How does the insurance pay your particular facility? Also, always have a self-pay option. You would be surprised, even today, there will be patients who have no insurance. One of my patients yesterday has no insurance, completely self-pay. And then there are insurances that will just exclude bariatric surgery or obesity as a diagnosis. So self-pay option, you want to think about. Don't put it down that, oh, it's not going to happen. It's better to think through these things when you start off and have financing options. By the way, traditionally, hospitals are not very good at coming up with financing options. So that's why I just want you guys to be aware of when you embark on this. Patient education and support. You have to have a comprehensive approach. That's the right thing to do for our patients, as well as the right image to provide when you're setting up a program. You have to have a solid team, a team that you feel comfortable, that will understand that taking care of obesity as a disease, not just having the credentials. The pre and the post-op care is important. The non-surgical solutions, I really do feel that we should embrace and we should offer. Most patients today are very well aware of the non-surgical solutions and not providing, excuse my pun, a solution to the disease of obesity, which is non-surgical, will limit the ability for your program to get used or utilized by the majority of the population, and definitely have an element of long-term follow-up, whether it's surgical or non-surgical. Patient engagement, education, whether it's in an individual setting, in a group setting. There are tons of resources available for this. ASMBS is a fabulous website and toolkit. Make the most of it. You don't actually need to spend a lot of money, but spend the time understanding the resources that are available. Walks, support group, engage on social media. Again, it's very simple. It doesn't cost you anything if you're running it yourself, and come up with simple events that could help keep the patient engagement going. Accreditation and safety, never compromise on it. And I'm going to say this many, many times. The only, I feel one of the reasons why I'm grateful I was able to be successful setting up 3 bariatric programs, by the way, in the same area, was because never compromised on safety and quality. And that reputation helps you. Don't think that it's not going to mean anything. It will. People today still want to know who the surgeon is, the referring physicians or healthcare systems look at that, the patients look at that. So just do not compromise on that. And MBS AQIP standards is your guide. When I came up with my contract as an employee, I literally took the MBS AQIP standards and I put all of that in my contract. I'm like, this is what I need for me to be able to start the program. reputation building, not just for yourself, but for your practice is vital, which is why whether you think about it that way or not, it does become your business to make sure that the front desk staff is coming across as compassionate or willing to listen to the patients. Because when they have a bad experience with any member of your team, guess who they think is not great? You. So you will ultimately get pulled into their impression of the program, whether it was you directly involved in it or not. Return on investment, something that it took me many years to really understand or pay attention to this term. So again, mistakes or lessons that I learned. So think about the return on investment from the very beginning. There's a huge financial investment if you're setting up a program for a hospital or for yourself. There's upfront capital cost. You've got to do a cost benefit analysis. If you're not comfortable doing it, have a consultant, pay somebody to do it. It's worthwhile. Long-term financial viability, you have to think about that. And if there's question about that, then obviously don't embark on that journey. The spin-offs are real, enhance the institution's reputation. A good bariatric metabolic weight loss program will definitely add significant value to the institution. At this point, it doesn't matter what the CFO and the CEO says. The reality is it helps the hospital. And it has a positive impact on other service lines, like radiology, like labs, like, HEMONC, Doppler studies. I mean, you guys know this, and know the value of what you bring in. Don't let other people tell you that, bariatric surgical volume is down, hence it's all bleak. That's not true. Why build a bariatric program today? Obesity is still a pandemic. Population health is a real important concept. The disease burden is real. The clinical economic benefit for treating obesity is definitely well established. And the need to address this health issue is stronger than ever before. The reason I put the but in there is because we all know how GLP-1s have really surfaced and been in the limelight when it comes to treatment of obesity. So the question is, what is the role of surgery? Should I really even be starting a bariatric program when 1 in 8 adults in the US is currently on a GLP-1? And my opinion, my personal opinion is it is more than ever before. And the reason is because now more people are aware that they need some help with the disease of obesity. More patients are reaching out for help. The reality is medications are not for everyone. I've always had a bariatrician when obesity medicine specialists did not even exist. And then, obesity medicine specialists and I myself boarded to be able to understand and have this conversation with minimum bias. So medications are not for everyone for different reasons. At the moment, there is no proper guidance or structure in place for when do medications come in, when does surgery come in. I use the cancer model. Is it adjuvant, neoadjuvant? How long should the patient be on medications? There's a lot of unknowns, which means there's an opportunity for us to be able to own this disease and to establish that criteria and structure. And who better than bariatric surgeons? We are the ones who understand this disease way better than any obesity medicine specialist for much longer. And we should own that and establish your credential. When you're talking to patients, administration, local people, make them realize that we understand obesity much more than anybody else. So you should be the one leading that. So surgeons are natural leaders. So it's easier for us to take that role. And because of what we understand of the disease of obesity, I feel like it's a no-brainer. But as surgeons, one of the things that I want us to be cognizant of, that we are just not technicians, and we should not limit ourselves just to be technicians. Then yes, our role in the impact of the disease of obesity will be limited. We must understand the disease, the pathophysiology, and the mechanism, how our different treatment options impact this disease. And when you understand that, then you'll realize that the comprehensive approach, offering surgical and non-surgical, has to happen. And there will always be a role of surgery, just has to be looked at a little differently. Reach out to your colleagues. For the interest of time, I'm going to go quickly here. Your specialist. Do not alienate. Do not consider yourself, for lack of a better word, knowing more or superior than your medicine colleagues. They don't like that. And that is the history we have. So when you're trying to build bridges and come up with a really, truly comprehensive program, reach out to them, make sure that they know that you understand how important their role is and how important your role is in helping their patients address obesity. So build bridges, earn trust. And I do recommend getting the obesity medicine certification. It's pretty simple and it'll just enhance your profile. Now let's switch to telling your story marketing. I know that we as surgeons, I mean, I find myself even today saying, why do I have to do this? Like, this is not why I went to medical school. This is not why I became a surgeon, that will figure out how to do TikTok and all of this. But you know what? The reality is, whatever affects your bottom line, whatever determines your ability to provide real access to care and take care of your patient becomes your problem. And so whether you like it or not, my recommendation is we have to be at the forefront, communicating to the public directly, telling your story. You can call it marketing, you can call it education, whatever way you want to call it. But we have to be able to be comfortable being in that position. And when you do that, just be yourself. Like, I'm amazed at how many dancing videos in the OR that I see. You don't have, I'm not going to dance in the OR personally to try to get a patient to feel comfortable with me as a surgeon, right? So I don't think we need to follow all the popular trends. Just be yourself. Ask yourself, do you have the passion to treat obesity? Do you care enough about this? Therefore, you will be able to figure out a way to get that point across. Be comfortable making videos and be comfortable with the social media platform, which you probably guys are all very comfortable. This is an older generation issue. But again, just be yourself when you're doing that. Hospital administration. So do not look at them as they versus you. You have to work with them as a team. You need them and they need you. Traditionally, it is you go up, you complain, there's something that's not working, you're absolutely right. But the way we approach it has to be less negative, more constructive, be cost affordable. For them, the bottom line is money. So make sure that you present your program as an easy, simple program for them to work with and something that's cost affordable, not just cost effective. Build your team. So I'm going to skip that for the interest of time. And in summary, I'm going to just say that today, having had the experience of building 3 programs, working in Northern New Jersey, which is extremely competitive, I still strongly believe that the community needs more help with obesity. Building a bariatric and metabolic program is an excellent next step for you guys, but really think through the earlier part of my presentation with the cost benefit and know your local market. Embrace change. There will be a lot of change coming in our field. Don't run away from it. Embrace. Collaborate with the different specialists. But in doing all of this, just never compromise on quality and safety and lead. We as surgeons should be the leaders and driving the treatment for this disease. On that note, this is my team. And I just want to throw in there that my hat of the TRIO Foundation. Would encourage all of you guys to look up what the TRIO Foundation is. We are running an AWARE campaign, and as well as going to be starting that disaster relief fund for the hurricane victims. So thank you for including that in the announcement. And that's it. Thank you.
Thank you, Dr. Majid. That was fantastic. Dr. Brethauer, take it over.
Yeah, good morning. I'm going to share my screen here.
And I can see it.
You can see it. Okay, perfect. Well, good morning, everyone. And thank you to Rickesha and Shaina for inviting me. And I agree, this is a great program that I think is really valuable to the fellows and those of us that are privileged to kind of give these presentations. It's always great to hear a lot of these different perspectives. And I come from a little bit different perspective than Saniea, from academic medicine, but have been really closely involved with the accreditation program and the quality improvement programs for ASMBS since really their inception. I don't have any financial disclosures. What I'd like to do today is just give you a little bit of history about how this all developed. This has sort of been an evolution that's occurred during my career, so I can provide a little perspective on why these programs developed and how we got to where we are today, and that we shouldn't be taking it for granted that it's just another thing to do. This is really important. And hopefully I can emphasize to you why accreditation and these programs really not only add value to the hospital system, your program, but to the patients. I'll kind of just review current state, where we're at with the MBS AQIP currently. And then I'm not going to go in great detail, but I'd like to just give you a high-level overview of what the standards are, because Saniea went through a lot of this in her talk, but the standards are very clearly laid out into different categories, and within each of those, there's subcategories of things, and it's really a playbook for you to use when you're starting a program, or if you're stepping into a program that's already mature. I'll tell you, if you're the surgeon and you really know the standards, and you want to be a leader in your health system, if you know the standards better than anybody, you have the opportunity to really ultimately become the director of the program, and drive quality, drive the program in the right direction. Without knowing the standards fairly well, you can kind of go adrift a little bit over time, and the program can suffer. And then I'm going to end with just a review of some of the national quality improvement projects that we've put together. And these are all based on our MBS AQIP centers and data registries, and encourage everybody to, as these continue to evolve, participate in those when you get out in practice. So I'm going to start with just a little background. So many of you probably aren't familiar with kind of how this whole Center of Excellence concept came about, but there was a burning platform that really ignited in around 2004, and it was really started by this paper published in JAMA by Dave Flum, and what it showed was he looked at mortality rates among Medicare beneficiaries who were undergoing bariatric surgery. This was data that was retrospective data, but what he showed ultimately was that mortality rates were much higher in Medicare patients compared to other cohorts. And in fact, if you look at the numbers, and I won't go through the whole paper, but at that time, 30-day mortality was 2%. This is, again, Medicare beneficiaries, 2% at 30 days, almost 3% at 90 days, and one-year mortality was nearly 5%. Think about that now. We had a 2% mortality. I don't think any of us would be in business, and certainly would not be, have the privilege of taking care of these Medicare patients, because they would have pulled coverage. And in fact, when this hit the presses, there was a lot of, I just put one headline up there, but there was a litany of headlines that came out in the lay press about how dangerous bariatric surgery was, and how, mortality was was high, and ultimately Medicare put forward a policy coverage decision that they were not going to cover bariatric surgery. And as you know, private insurance often follows the Medicare's lead on these things. And so this was a really a critical time for our specialty. So when Medicare came out with this policy coverage recommendation, they wanted, put out a call for comments and things like that. But as a society, and Harvey Sugarman was really heavily involved in this, along with the college and other leaders at the time. They basically negotiated with Medicare that if we can put together a Center of Excellence program to really govern ourselves, put in standards, put in data registries that are meaningful, and that we track our own outcomes and have the data to support that we're getting safer, that we can do that, and Medicare would continue to support and cover the procedures. And in fact, that's what happened. So there was a lot of activity around this in the early 2005, 2006. And ultimately what happened was there were two programs that were developed. The American College of Surgeons developed their bariatric surgery network, and that was kind of their Center of Excellence program. Started in 2006, and it started out with about 125 centers participating in that program. And that was really kind of, along with the ASMBS's program, the foundation of what we have today. At the same time, this ASMBS developed a Center of Excellence program, and it was run through a separate corporation called Surgical Review Corporation. Both of these programs were pretty similar in terms of what the expectations were in terms of data collection, providing resources around the patient and within the program to keep things safe. But it was really that data collection piece that we hadn't had at a national level before, and that's what Medicare was basically demanding that we do. The Center of Excellence program for ASMBS started out in 2005. More centers involved in that. And then as time evolved, it became more clear to us that we really just needed one program, because some programs were kind of participating in one or the other, and a lot of them were participating in both to meet specific requirements of the private payers. So it just made sense for us to consolidate. And so in 2012, those programs joined to what is now the MBSA QIP. And this, again, sounds easy, but this was a huge lift for, two large organizations to come together with the leadership. And really, we had some really key leaders at the time driving this initiative so that we had one unified program. So that was put together in 2012. And as we put together that program, we had to really rewrite and reinvent all of the standards, all of the expectations, and we had to build a data registry from scratch. None of the legacy data from these other two programs was carried over. And so this was a big lift for the specialty, for leadership, for the college, and for the ASMBS. And we had great leadership at the time that really guided us through this. And so when that got kicked off, there were 800 centers. And you can see today there's over 950 centers involved in participating in MBSA QIP. So that's kind of the evolution of things. And I think it's important to remember that burning platform that we had to deal with 10, 20 years ago, because those risks are still out there. If our outcomes suffer, if we don't have the resources around our patients to rescue them when they have complications, people are still always looking for a reason not to cover specific surgeries. We have done a great job within bariatric surgery over the last 10 to 20 years in improving our data, and not just improving our data, but letting people know how good we've gotten. If you think about a 2% mortality rate in your Medicare patients 20 years ago, it's probably 0.2 today, or less, 0.08 or something like that. I mean, these mortality rates have dropped tremendously. And there's lots of reasons for that. There's, formal training that's evolved. There's, the laparoscopic techniques. There's just more experience with these patients and how we do these operations and the technology. And certainly accreditation is not the only reason we've gotten better, but I do believe it's one of the key drivers behind why we've gotten better and why we can show that we've gotten better to payers. Along with that program came a very formal organization within the college, American College of Surgeons. So if you think of our program, it's exactly like the other college quality programs. It's just like the Committee on Trauma, the Committee on Cancer, the Pediatric Accreditation, Emergency General Surgery, Geriatrics. It's just one of those, it's in that whole portfolio of quality programs within the American College of Surgeons. And within each program, there's a pretty robust infrastructure to support the program. So Lisa Hill's our program manager. And then we have our own statisticians. We have people who deal directly with the centers all the time to answer questions and help them through their site visits. That we run the site visits and accreditation process. And then we also run our quality improvement projects through this group. But this is all done in alignment with ASMBS. And so while the kind of the machinery of the program is owned and run by the college, the leadership of the program is ASMBS leadership. So I currently serve as the chair of the Committee on Metabolic and Bariatric Surgery. And then there are co-chairs for the two different advisory councils. We used to call them subcommittees, but they're standardizing the language. So these advisory councils really are the standards and verification group, which is the group that really every few years relooks at our standards and our verification process and adapts to the current landscape of what's happening to make sure that we're, the things we are asking programs to do are meaningful, relevant, and hopefully add value. And then the Data and Quality Advisory Committee, our job is really just to make sure that the data variables that we're collecting are still relevant, and that the registry is robust in terms of what metrics are meaningful, and our risk-adjusted reports models are still relevant to what's happening out in the field. And we also run the National Quality Improvement Projects that I'll mention at the end. And this is all done with a lot of great leaders. And I'll just make a pitch for you. If you're interested in quality leadership, getting more involved, as these typically are 3-year terms on these committees. As you evolve through your practice, if you get more interested in this kind of work, you can always reach out to me or Lisa Hale, or the current chairs are Tony Petrick and Dana Tellum for data, Rich Peterson and Teresa Lemasters for verification. Reach out and say, I'd like to get involved in some of these committees because you'll learn a lot. The other thing I will pitch to you is the opportunity to become a site visitor. There's no better way to know the standards and know what's going on out there and learn from other programs than to be a site visitor. And so as you mature through your own career a little bit, kind of get your momentum in your practice, typically we want people out in practice for a few years before they become a site visitor, but it's a great opportunity, down maybe a few years down into your career to really get embedded into this whole process and culture of MBSA Equip. So there's, again, two parts to this. There's the accreditation piece, which are the standards that are expected to be followed. Those are very prescriptive and measurable and verifiable. And then there's the data registry. And we're the only national data registry that is collecting data on every patient that is getting bariatric surgery. Some of the other programs, you may know, NISQIP is a sampling. Some of the other programs collect data in different ways. We collect robust data with a lot of clinical variables on every patient that gets a procedure in our programs. And so, as you can imagine, our data set is very robust. And this data is entered by somebody who's a trained abstractor. We call them clinical reviewers that are independent from the clinical practice. And those clinical reviews are periodically verified for accuracy. But it is one of the better data sets you'll find in terms of national registries. So there's different designations for the programs. We know that as time goes on, practices change. People move from their big center to smaller hospitals or ambulatory surgery centers. And we want to make sure that as we move into revising the standards, that we're keeping pace with the changes in the landscape of bariatric surgery. And so, a lot of that's reflected in some of these. We used to just have basically a comprehensive center, with or without adolescent accreditation. So I would say, and I'll show you, most of the centers now are comprehensive, but what that means is that you've done at least 50 stapling procedures annually. It's not a high bar, but we feel like there is some volume outcome relationship, at least with bypass procedures or anastomotic procedures, but that's the number that we've kind of landed on over the last few years. And that anybody over the age of 18, and you can really perform any of the ASMBS endorsed procedures. Those are all listed on the ASMBS website, but I'm sure you're familiar with what procedures are kind of current practice. And you enter all of your data on those patients. If you want to do adolescents, then you usually are paired with a pediatric surgeon or pediatric adolescent surgery or a children's hospital. And so there are a separate set of standards for those patients that have to be adhered to. And then a lot of the large academic medical centers have the comprehensive with adolescent qualifications, as we do here. And we partner with Nationwide Children's to make sure that program runs smoothly. Something that's fairly new is the obesity medicine qualifications. I was seeing in the chat all the folks that have done their bariatric or obesity medicine boards. Highly encourage you to do that. It adds a level of credibility, I think, to your practice when you not only do the surgery, but you're really an expert and board certified in the disease of obesity management. And so we have recognized that as, part of the program accreditation is that you can be a surgical comprehensive center with, and add that obesity medicine qualifications. That has been primarily a documentation thing showing that, we have the people and the expertise to meet that qualification. We are now moving towards more data collection within our registry to capture some of the variables that are meaningful to the obesity medicine piece of the practice. And so that's a work in progress. And then you can have all three: obesity medicine, adolescent, and comprehensive. And then there are low acuity centers. There are certainly, we want to make sure that we're not, limiting access to care. And so there are low acuity centers, and these are really more of the smaller community centers where there's just not the safety nets around the patient or the resources to meet the requirements of a comprehensive center. And what this means is, the volume numbers and requirements are a little bit lower, and the patient selection criteria are a little bit more restrictive. In other words, typically low acuity centers, we don't allow like complex revisional cases, patients with organ failure, like chronic kidney disease, heart failure. Some of those more high risk patients just should not be done in these settings where there's not a robust ICU or interventional radiology or those kinds of resources. But they can certainly do the standard cases, low risk cases, do them well, and then have transfer agreements with larger institutions if they do need to transfer patients. So if you start out in a smaller program, it's low acuity, and the resources just aren't robust enough for a comprehensive designation, that doesn't mean you can't be accredited and collect your data and really provide great care. There are adolescent onlys, which I doubt many of you are going to go to work at a children's hospital, but that's an option for programs where there's a kind of a standalone adolescent program. And then the last set of standards included ambulatory surgery. And we know that more and more cases are getting done in the outpatient and ambulatory setting. The data collection was not good. So we were hearing a lot of people say, we want to do our sleeves and even our bypasses in the ambulatory center. And now people are asking to do revisions in the ambulatory center. And so we weren't getting good data because there wasn't a designation. So we decided, let's make it a designation. Let's collect the data and let's see how we do in terms of outcomes with some guardrails around patient selection. When we recently looked at the data, those centers do quite well. In fact, we just looked at the other night at some data on band to sleeve within the ambulatory surgery centers. They perform, very well. No major complications, no mortalities in those centers that were performing bands to sleeves, and so that helps make the case. We have the data now that it's okay to do those with the guardrails in place. And as more and more of us, move some of our practices into that setting, we want to be able to capture that data and follow any trends. So those are the designations. And so currently we have 967 accredited centers in the country. Just to put that into perspective, we're second only to cancer in terms of the number of sites participating for the college. And so this has really not only just taken off when we consolidated in 2012, but grown. We've included some international centers that want to collect their data. They don't participate in the verification process, but they're able to collect their data. And we always have centers that there is some attrition just with centers programs closing, but we're continually recruiting new sites to participate. And there's an ongoing accreditation process that our site reviewers and team is really all the time, going out, doing site visits. And just so you know, the site visits are done on the initial designation and initial verification, and then every 3 years. In the intervening years, we ask that centers submit interim reports on their outcomes and quality improvement projects. But the site visits, which are primarily done virtually now, are every 3 years. And you can see in that graph that most of the centers that are currently accredited are purple there. That's the comprehensive plus or minus adolescents. And this is just a map kind of showing you where those accredited centers are. Depending on your region, it may be hard to find a program that's accredited, and certainly on the coasts, it's very easy to find centers that are accredited. If you're joining one of those practices, I encourage you to really learn about the standards, get involved in the program. And as Saniea said, don't just be a technician, be an expert on the care of obesity and what these standards bring to the care of our patients. If you look at the registry data, this is over time grown. We had obviously a dip in COVID, and now we're seeing a little bit dip related to the GLP-1 agonists. But I think over time, I anticipate over the next 5 to 10 years, we'll continue to see 5 to 10% growth per year, depending on what's going on, in the greater arena of obesity care. But lots of data every year. Around 200,000 cases get entered in the registry every year. And I'm just going to run through the standards at a high level. This is a book that's available to you. You can look through the standards as you go into practice, or if you're starting a program. Again, this is your playbook. This is the things that you need to put together in your business plan to make sure that you have the support and the resources that are needed. And the question is always, well, why do we have to do this? Can't you just do the surgery? And your answer to leadership should be the best practice and really the standard for performing bariatric surgery in the United States now is to perform it within an accredited program so that the resources are around to make sure that patients are well taken care of in the operating room, but their entire continuum of care supports them in terms of the people, the multidisciplinary approach to the disease, the equipment, the chairs, and the education that goes on within the facility as well as with the patients. And so it's an investment for sure to get these programs off the ground. But I think, as Saniea pointed out, the bariatric surgery programs that are run well are, they're contributing to the margin for their health systems. They're not a drain on resources in the long term. So part of that is that standard one, it's an institutional administrative commitment. It seems fairly obvious you'd want to have your leadership buy in on this, but it's really important that we have documentation that those meetings have been held, that they have agreed to support the program, provide the resources, and the equipment and things like that to make sure patients are well taken care of. And this is a formal process as you get a program. And when we do site visits and verifications, we expect hospital leadership to be at those site visits and express their support for the program. And one of the things we see sometimes when programs are not fully accredited or have remediation, it's that institutional support. And that can be reflected in the fact that, they just didn't fill that FTE for the clinical reviewer or the dietitian, or you're sort of getting whittled away in your program, and that reflects institutional support, and we want to see that really strong for these programs. The program scope and governance I kind of went over, but these are really the designations, and you can read through the standards and see how those break out, but it's primarily based on volume. And again, the facilities and equipment resources, this is something we also look at on our site visits. Obviously, you want to be accredited for whatever, usually it's Joint Commission, it's really to make sure that the environment the patients are in is safe, and that the equipment is appropriate for patients that are large, and that's something that we actually look at directly on our site visits, and you want to make sure that that's all done and taken care of and documented well within your program. And then it's really important, as you go out into practice, credentialing guidelines, the ASMBS, the college, do not get involved in credentialing. This is a local process, but what we do require is that there is a separate set of credentials for bariatric surgery. You can reach out to anybody at the college, myself, anybody. There's templates or standards or boilerplate credentials for bariatric surgery. But when you get your credentialing, make sure that it's not just part of the core general surgery privileges. It's a separate credentialing set of credentials that has to go through your credentialing board, get approved, and that you have to, continue to re-credential however often you do it. We do it every 3 years. But it's really important so that not anybody can step in and do a sleeve here and there if they feel like it. These are clear-cut credentials. And then you have to have patient protocols. So these are pretty prescriptive as well. I'm not going to go through all of them, but there's patient education pathways, there's VTE prophylaxis pathways, there's anesthesia care. A lot of our enhanced recovery pathways are included in here and sort of span the breadth of many of these different pathways and the continuum of care. But these pathways are really important. And what is important when you have a site visit is that you have the pathways, but you're also following them, and you can document that you've followed your pathways. The data we talked about, and this is, again, robust data set. It collects preoperative data or intraoperative data, postoperative data out to 30 years. And then we do have long-term data variables to 90 days and, 6 months and 1 year. That follow-up is not great. That's something, an initiative that we're working on to get better long-term data. But you can also create custom fields. Your clinical reviewer, you can work with them on a quality improvement project to create your own variables to track, a quality improvement project. So you collect that data prospectively, and you have a great data set when you want to see how your quality improvement project is working out. You can get access to your data anytime, and it's non-risk adjusted, but it's a signal if there's trends in certain areas. And then the semi-annual report is a risk-adjusted report that allows you to benchmark your performance on different procedures and different outcomes against national averages. And then there's the PUF, which is the yearly participant use file that is used for research that you can access. If you're an accredited center, you have free access to the PUF. You can access the files and then mine that data for research. We're running a little short on time here, so I'm going to go through this a little quickly, but I would say one of the biggest deficiencies we find in our site reviews is the quality improvement piece. You're required to do a quality improvement project every year, and those are highly variable in terms of the types of projects being done, as well as the quality of the quality project. They're often not high quality or robust interventions. And so you really want to base your quality improvement projects on standard methodology, have a problem statement, have very specific aims, and a timeline. And then you want to base it on your risk-adjusted outcomes. And so this is an example of a SAR. So this is for sleeve, and the column on the left are all your different models. And then it shows you your volume for that, the number of events for these models, the predicted or risk-adjusted observed rate, and it gives you an odds ratio, and it puts you in a decile that tells you, a high performing, low performing. If you're in the high outlier, that means you're statistically outside that error bar. And those are the areas that you need to really drill down on. And you can drill down it to the patient level on these reports and figure out what's going on in these patients with, sleeves that are having post-op morbidity and, interventions. If you're not an outlier, if you got a great SAR, there's other things you can work on for your quality improvement projects. And we now have this QIAR report that we'll show you if you're a high outlier, and this is to help guide your quality improvement projects. But if you're generally doing well, it can still show you like where your opportunities are. Even if you're not statistically an outlier, you're as expected. It'll give you sort of a benchmark to say, well, you're doing great, but here's some opportunities. Compared to your peers, your readmission rates are high. So why don't you focus on that for your QI project? And then education, the patients, the faculty, doing grand rounds, doing all of those things, but really providing the support for the patients pre and post-operatively is another requirement. And I'll end with our QI projects that we do nationally. We're currently in our 4th project. The first one was around readmissions. The second one was a enhanced recovery project called Energy. Then we did B-Stop, which was decreasing opioid prescribing. And now we've kind of taken a spin-off of B-Stop to focus on the discharge prescribing. We've provided an algorithm or some guidance around discharge prescribing at the time of hospital discharge. What we found in B-Stop was that the centers did great at decreasing their inpatient opioid prescribing, and then everyone was still going home with 30 oxys. So we saw that as an opportunity to educate and try to put some a little more prescriptive guardrails around, like if you don't get any opioids the 24 hours prior to discharge, you shouldn't go home with any. And then 5 and 10 sort of relative to how much you need in the hospital. And so these are big projects. The sites collect their own data and a custom field for us. And we can not only measure outcomes, but we can measure how well they're adhering to the different process measures that we put in place. And so this is about 230 sites. B-Stop was about 330. And so these are big projects, and we get great data from it. And we really want to focus on things that are meaningful to our sites and the patients. And one other thing I will mention is this fulfills your requirement. If you participate in one of these national quality improvement projects, that fulfills your requirement, standard 7.2, to complete a quality improvement project for usually the 2 years that you're involved in these projects. And so we just completed the run-up period and the baseline period. We're in the data collection period for B-Stop D now. So in about a year, we'll have some data to share about our discharge prescribing practices. So that was a lot, but I hope that kind of gave you a nice overview of the program, where we came from, where we're at, what's important, and always reach out to me if you have any questions or issues, or as you get into practice. Our team at the college is great. They take calls all the time from directors and program coordinators to say, hey, I've got this issue, what do we do? And they're very responsive. So it's a great team. I didn't leave much time for you, Linda. I'm sorry.
Yeah, no. Thank you so much. I'll hand it over to Linden for your announcement on the toolkit.
Thanks. So let me share really quick for a second. I don't have a ton to share, but so I'm the co-chair of the rural committee, and last year we did a survey looking at hurdles to accreditation for our membership, and our membership being made up of often, small, lesser resourced programs. And one of the biggest things, a couple of the big things we found were issues with collecting data. We didn't have staff to collect data to get us to accreditation. We lacked some of the institutional support. A lot of the things that Dr. Majid talked about, just getting administration to understand the importance of data collection and having enough staff, and why we would want to apply for accreditation. And QI was another big thing that stuck out to people. So what we decided to do is pool all of our resources in our programs and create a toolkit to help with guidance as you go through the accreditation process, your initial accreditation process, and then also just some of the paperwork that bogs you down. When I started a program straight out of fellowship with Dr. Brethauer, it took me 3 years to get my site visit scheduled. I had case volume within a year, but I couldn't get all the other components in line. And a lot of that was documentation and data collection because I was just essentially doing it by myself. So we're waiting for EC approval to get our toolkit up online, but you'll see it on the ASM website under toolkits, hopefully in the near future. And then it's basically we have something for everything. So I pulled up really quickly, like one of the things that Dr. Brethauer was talking about with the QI, figuring out how to make a QI project. So we have a tip sheet for, creating a QI project, looking at your data. Again, it's one thing to make a QI project based on your SAR, but if you're applying for the first time around, you got to really think, what can we improve and how do we do it, especially when you maybe are in a hospital that doesn't have an IRB, you can't, or you don't have residents or fellows to help you collect data. These things are challenging. So this is like a tip sheet for how to come up with a QI project. We have just some ideas for possible QI projects based on things that we have seen and we have done amongst our committee membership. And then we have other stuff that's a little harder to come up with, like for example, Dr. Brethauer was talking about low acuity centers and then how you have to have a transfer agreement with a bigger center, which I love that actually he's on this because my transfer agreement in my first practice was with The Ohio State University. So he was my backup when I was in a small rural health system. And so for that, was that in facilities? I can't find it now, of course. But we have it all. That's my point being, we have it all. And if you're looking for this, if you're actually getting started in a practice right away, and it's not online, please reach out to me. My email address is here. I can help you get access. We have it all in a Google Drive right now. So we're happy to share access to these things even before they're up on the website, because I'm a pretty firm believer in the fact that we should be starting new programs and building access. I agree with Dr. Majid. I think that that's the future. Bariatric surgery is not going away. The need is not going away, even with GLPs. And there's lots of places that need it. I started a program halfway between Cleveland and Columbus. That's about a 2.5-hour window between Cleveland and Columbus. And you don't think that that's that far, but that's far for people who maybe don't have transportation and the population that I served there was really a population that wasn't going to get bariatric surgery in Cleveland or Columbus. The only reason they got bariatric surgery is because there was somebody local doing it.
Thank you so much, Linden. I think that might be all the time we have, but excellent talks on the resources and what's possible after fellowship. I think my next step is trying to become a site visitor. So I'll try to do that. But Shaina, do you think we have time or should we just end it there?
I do think let's ask Sierra and Grace Chow's question. For those who need to leave, totally fair. We're just going to run a few minutes over, ask that one question, and then we'll end the session. So I think hearing Dr. Brethauer and Dr. Majid's perspective would be great.
Right. And what question was that, or just asking?
Oh yeah. So what are some of the barriers for collecting data beyond 30 days post-op MBSA equip and having it kind of available through like a patient user file? Considering how amazing the data set is for 30 days, is it available or an option to get it to 1 year to better inform us?
Yeah, we just agreed at our committee meeting 2 nights ago to include the 6-month and 1-year data in the PUF. So you'll have the data. I will tell you that follow-up at 6 months is around 70%. So decent, not great, but not horrible. Follow-up at 1 year is around 40%. Having said that, the argument was made, and the reason we decided to do that, it's 40% of 150,000 patients. And so we felt like even though the follow-up rate is low, it's a limitation, there's still potentially a lot we can learn from that amount of data. So we will be putting the 6-month and 1 year follow-up data for those patients in the PUF moving forward.
Mm-hmm.
You heard it first here, guys. That's great.
Okay. Breaking news for sure. And, for fellows thinking about, what jobs or practices will they join, should they not consider an MBSA QIP accredited job if they found one, or should they have the hope of, hey, I'm going to join and maybe I'll try to help build that? What should the standard be for those looking?
Let Saniea answer that one.
Yeah, so great question. By the way, I personally, I just want to give a shout out to MBSA QIP and all the work that's put behind. It's a lot of work to put behind this, and has always been my go-to when I'm trying to negotiate with anybody regarding what our patients need. It's a great resource. So thank you for working towards that. So in terms of the job, honestly, the reality is, as we know, for the ones graduating next year looking for jobs, don't be picky, right? The volume of bariatric surgical cases across the country have, for the short term, gone down. There's so many variables that go into selecting a job. So if it overall looks like it's a good place to start, you have people who will support you, then whether it's MBSA QIP credit or not, I would not let that be a deal breaker. Why? Because we have the resources to help you get to an MBSA QIP accreditation place. Sometimes it takes longer than others, but at least it's very feasible. And this is coming from a person who never had the opportunity to start a program that was already there. So I can tell you there are tremendous resources. Wow. Ask, and a lot of people come out and help, much more than you would even expect. So let that not be the deciding factor. If you do if everything is equal and you have an accredited program and this is your first job out of fellowship, take the easy way out. It is a lot of work to start a program. There's no question about it. But if you have to start a program, I mean, we as surgeons, that's what my bias is clearly for surgeons. We don't shy away from challenges, right? That's why we are natural leaders. So that would be my 2 cents.
And the program's set up so that you can basically start, at some point, get your resources around you and collect some data, and then start as a low acuity, build your practice, and then move to comprehensive. It's not all or nothing forever. So it's built to grow in a stepwise fashion. And I started a program at Fairview Hospital at the clinic. Even in that, system where you'd think, be a no-brainer, just start a program. It took about 2 years to start a program at that community hospital. So it's a lot of work, and you got to just really stay on top of stuff. But it's worth it. Once it gets off the ground, it's really worth it. But just be patient, be persistent.
So even within a larger system, if some of the fellows are taking maybe regional jobs within a system, they can still have a different, maybe a low acuity designation that they can go out.
It's hospital-based, so it's not program-based. We are looking into maybe some verification around programs, but right now it's a hospital-based program. So for every hospital that's doing it has to have their own accreditation, and it can be different designations even within the same health system.
Some people say that it can be a little bit easier if you're starting at another hospital in a system that's already established, just because you can borrow some resources from the established programs. And that's what, when we surveyed everybody in the rural committee, that was something that was offered as an option by a lot of people. But according to our survey, about a third of our respondents took less than a year to achieve accreditation, and several took over 5 years. So there is a very broad swath of how long it takes based on what resources you have.
I think part of that, and this goes to some of the points Dr. Majid made at the very beginning of, you need to learn how to talk to your administration. part of this buy-in and part of the build is how we collaborate, not compete with the people running our hospitals. Some of the best leaders in the country administratively are actually surgeons. And some of I think Cleveland Clinic is one of them, run by a surgeon. And having surgeons involved in administration will help with time. I think achieve these goals a little bit faster, but coming out of fellowship or being a newer surgeon, learning how to collaborate and liaise and talk in the same language as an administrator is really important to achieve your goals. So you can go from, instead of greater than 5 years, to something closer to 1 or 2 years. Most people are really going to be, to the Dr. Karras and Dr. Brethauer's point, somewhere between 2 and 3 years to build. Even with buy-in, you have to have the decision makers, the people to willing to turn on the money to hire people and to get your space. I think negotiating some of that up front, or as much of it as up front as possible, will create that foundational language for you to be successful. Learning lessons of learning from my first few years for sure, and something I'm doing right now. All right, we are very much over 13 minutes. I just wanted to thank you guys. This is such a great conversation, great talks. I measure the quality of the morning based on how many screenshots I took, and I screenshotted the entire time. You guys couldn't see me. So I really appreciate the opportunity to have you guys on as leaders, Dr. Brethauer, Dr. Majid, Dr. Karras. Dr. Wilson, thank you for being my co-moderator and leader in this realm, and we really appreciate your time. We look forward to the 3 p.m. Eastern session, where we'll go through this again and have opportunity for more questions and answers with Dr. Samakar and Dr. Neff. Y'all have a wonderful Friday.
Thanks, everybody. Have a good one.
Thank you very much. Thank you.
Well, that was a very educational presentation. Thank you so much for participating and attending. At this point, we would open this up for questions from our audience.
Yeah, thank you both for being here. Just to orient you, Marc and I are the BST Fellows Project surgeons who are the hosts for the afternoon session, the West Coast session. So appreciate you both not only doing the morning session, but jumping on for the afternoon folks to answer questions.
Yeah, you bet. Thanks for having us.
Thank you.
I'll bring up one thing that came up this morning, and that was the PUF long-term data. So traditionally, we have limited the PUF data to 30-day outcomes. We've recently looked at the data at 6 months and 1 year. And while follow-up is not great, it's not ideal, we have about 70% follow-up at 6 months and about 40 to 45% follow-up at 1 year in the registry. We realize that that's still 45% of 150,000 patients, and there's probably some meaningful data that can be gained from looking at that data, and it may generate further ideas about how we can improve our follow-up. So in PUFs moving forward, we will be including the 6 month and 1 year data for people to take a look at.
So there's no current questions in the chat. I feel like I want to monopolize maybe some of your time for my own questions. So a couple things. So I'm in Los Angeles, and I'm involved with a program in a large academic hospital. We currently do, but I've heard that there are programs like the Mayo Clinic that has quality carve-outs for specific patient populations. Now, this may or may not be true. But for instance, liver transplant. Obviously, we want to ensure the best quality outcomes for all of our patients, but it becomes a little bit of a difficult thing to ensure that we are complying with what is expected and exemplary in our SAR, but we're also providing services for patients that are obviously going to be in the highest category of severity of illness.
Yeah.
Can you comment on that?
Yeah, we have excluded a couple conditions from the SAR. So LVAD patients, and then patients who get bariatric surgery simultaneous with transplant, and then cirrhotic patients who, in not just chronic, liver disease, but patients with clear-cut cirrhosis who undergo a procedure. Those are now, being excluded from the risk adjustment. So those are really kind of at the extreme high end risk. There's certainly other patients that puts your program into that high risk category, but we have made an effort to identify at least some of these really big outliers that obviously stay in the hospital for a long time, have a known much higher complication rate, and have excluded them from the SAR.
And that's across the board for all programs.
Yeah.
Okay, great.
We have a question in the chat about how long would you typically follow up your routine cases to keep track on the database?
Well, I mean, we want to follow our patients forever, but understanding that patients often after a year or so get back to their primary care physicians or just are lost to follow up. At a minimum, we really want to get data out to 1 year. So I think most programs plan at 1 year follow-up visit. It's just that the no-show rate's pretty high. So at the central level, I think a lot of work can be done to try to round those patients up at 1 year, get them in and see how they're doing and document their progress. But the case can be continued indefinitely. If they're following up every year for 5 years, that data can be included in the registry for that patient.
Right.
I'd be very excited to throw a question out there for both of you. Something I have struggled with over the years, and I imagine some of our fellows might be thinking that too. How do you create a business plan?
I'll let Saniea take that one.
So, I mean, I don't have an MBA. I would never have thought, I'm a nerd. Like physics was my favorite subject in school. So, I understand how daunting it could look like, but honestly, it's not as complicated. You know, like anything else, when you don't know something, it seems much more complex than it really needs to be. You need to know what you need, right? So that's why the MBS AQIP standard has been really helpful for me. Facilities, staffing, everything, right? Put it all down in one Excel spreadsheet. And then the fair market value, like what would be the average cost of XYZ. What I outlined in my presentation basically touches upon that. You need to know what you need to put forward, what you need, and then how much you can expect to get in return, which is based on your insurance contracts and local competition. What are the numbers? And today, these can actually be, you can make pretty good calculated estimates and then project what it is going to look like. For bariatric surgery, typically, it takes 3 to 6 months before we do our first case. And that's the hardest part. When you go out on your own, is that who's going to fund the first 3 to 6 months. But I mean, private practice is a whole different discussion, but starting a program to have that support the first year, would be, I would say, make sure you can manage for the first year with some support. And then year 2, you should be able to kind of work towards breaking even. It's an Excel spreadsheet and knowledge and a calculator.
And I would add, I mean, I do have my MBA and I still have to get with an administrator to work out the details and present it in a way that speaks to the leadership and the C-suite. So find a good partner on the administration who can champion your cause with you. And as Saniea said earlier in her talk, they're a really valuable partner in developing the business plan. And they've done this for a lot of different things. So they can take what your needs are and put it into the format and crunch the numbers for you a lot of the times.
Absolutely. And I think that to reach out for I don't like the word consultants, but people who do this probably for a living and just pay them a little bit to do that for you might be more beneficial in terms of time.
I just, for the sake of time, I noticed there are two Stacy Brethauers on this call. I think, is that Dr. Karras that's on this call?
That's Linden. I'm not sure why her screen has my name on it, but that's
and
Linden.
so thanks for joining. We were instructed to figure out a way to incorporate Q&As as well as have you give a plug to the resources that are available. You want to go ahead and do that now then?
We can't hear you, Linden, unfortunately. Don't get in a wreck.
Yeah, please. Whenever you're ready, we're happy to have you. We you know, the instructions were vague, so to speak.
So Linden, I'll speak until she gets her volume up. Chairs the rural surgery committee, and they put together a nice toolkit in terms of resources and checklists and things like that to help develop a program when you're starting a practice in a program in a rural setting or a small community hospital.
Can you hear me now?
Yeah, we can hear you now.
Yes, go ahead.
All right. Thank you, Dr. Brethauer. So unfortunately, I'm trying to squeeze too many things into my day, and so I can't share my screen anymore because I'm in the car. But over the last year, the Rural Surgery Committee has come up with essentially an accreditation toolkit. We polled our membership and saw that it can take up to 5 years for new, small, under-resourced programs to get accredited. And so what we did is we came together and created basically a database of templates and spreadsheets and tip sheets and examples to help with the kind of the paperwork aspects and some of the more difficult ideas that they ask us for accreditation. So, for example, it's hard when you're starting a program. Nobody's going to hire you a clinical reviewer when you have no cases. So you have to end up doing we have a template spreadsheet for you to fill out with that information, or for somebody in your office to fill out with that information as you do your surgeries. We have
the limits of our technology.
Like the administrative letter of commitment for that you can give to your administration to help them write their letter, sample transfer agreements, sample education materials, all this kind of stuff that just is aimed to make the paperwork easier when you don't necessarily have a lot of help. And so the toolkit's not on the website yet, on the ASMBS website yet, as we're waiting for the EC to approve it, because they have to approve every single piece of paper before it goes up. But we have it in a Google Drive. So if anybody is wanting to see it ahead of time, please just reach out to me. I'll try to put in the chat my email address so that people can just reach out. And actually, somebody who was on the morning call already emailed me asking me for access to the Google Drive toolkit, because it's very, very helpful. It took me 3 years when I started my program out of fellowship to get my site visit scheduled. And it wasn't, I had enough cases after a year, but it was getting all of the other ducks in a row. And I started my program at, as Dr. Majid recommended, and I used the standards as a guideline. I modeled everything after the standards. So it's not like we weren't adherent to the standards. It was just getting all of the paperwork and the ducks in the row and the proof and the database of data. And so we're trying to make it easier for people to build new programs, because I think that's really the future.
Well, I appreciate you joining. Out of respect for everyone's time, I know that people have to jump off. I think there's more than 24 fellows that have benefited from this, and I think that you guys have all been incredible speakers and resources. Marc texted me on the side saying, "Hey, it'd be great to have a business plan toolkit." I think what you're offering, Dr. Karras, is part of that, and it would be interesting if the ASMBS could put together more of those resources for not just fellows, but people on practice that could share from the common experience.
Yeah, I agree. I could take that back to our team at the college and see what we can do to formalize some of that work. I'm sure they have many examples of all this stuff that we can try to consolidate.
Yeah, I'd be happy to contribute some of the ones I've come across or I've used along the way.
Great.
Well, thank you all. Have a great rest of your day and enjoy the weekend. Thanks.
Thank
you.
Thanks, everybody. Have a good weekend.
Thank you. Yep.